A very good evening, aspirants. Today's the class of general topic of EDIC Part 2 would be conducted by Dr. Ashutosh Kumar Garg. He is head of department in KAILASH DEEPAK Hospital at Delhi. His area of interest is in mechanical ventilation, hemodynamic monitoring, renal replacement therapy, and nutrition. Over to you, sir. Now you can proceed with your lecture.
So today I will cover the topic cardiovascular system, case based scenario, and start with a case and then some computer based assessment. So this is a 54-year-old man with a history of non-insulin dependent diabetes and hypercholesterolemia, present to the emergency room with 1 hour of left arm discomfort with associated dyspnea, nausea, and diaphoresis. He also noted palpitations and lightheadedness. On arrival to the ER, he was given oxygen by nasal cannula and attached to a cardiac monitor. His medications included metformin and glimepiride combination and atorvastatin. On physical examination, patient had marked diaphoresis. Blood pressure was 105 by 60 millimeter of mercury. An irregular pulse of 115 beats per minute, respiratory rate of 22 breaths per minute. Lung exam revealed few bibacillar rales. CVS examination S1, S2 normal and S4 gallop. The abdomen soft and extremity examination unremarkable. His laboratory values was hemoglobin 13 gram per deciliter, WBC 10,000, hematocrit 39%, ABG on 2 liter of oxygen, pH is 7.46, PO2 86, and PCO2 34 millimeter of mercury, bicarb 28, BUN 17 milligram per deciliter, creatinine 0.9 milligram per deciliter. Chest X-ray and ECG in coming slides. This was the ECG. So can anybody tell me what is the interpretation of this ECG?
ST elevation in V3 to V5.
Okay.
Acute lateral wall MI, sir.
Okay. What about first and AVL?
There is also elevation, 1 AVL.
Okay.
And there is depression in 2-3 AVF, reciprocal ST depression.
Okay. So whenever you make a diagnosis of myocardial infarction, you should also see the reciprocal changes. So if you are suspecting any anterior wall MI, you should see the reciprocal changes in the inferior leads, second, third, and AVF. And if you are looking for inferior wall MI, then you should see the changes in the first AVL or maybe V1 to V6, depending on the infarct area and culprit vessels. So this was the X-ray. Is there any changes?
Yes, increased perihilar bronchovascular markings, so probably some congestive heart failure is there.
Okay, so little bit of bat wing appearance, or you can say perihilar shadows or bronchovascular margins prominent. So you can say, especially when you have the information in the form of history. So you can say this may be the changes of the congestive heart failure. Okay. Then sublingual nitroglycerin was administered without relief, and eventually morphine sulfate was given to relieve his symptoms. Thrombolytic therapy was initiated with intravenous TPA, and heparin was begun with a 5,000 unit bolus and 1,000 units per hour continuous drip. Aspirin 160 milligram per oral was given. Because of frequent episodes of non-sustained VT, lidocaine therapy was initiated. Patient had persistent tachycardia and metoprolol 5 milligram IV given 3 times. Over next 3 hours, his symptoms were not ameliorated. In addition to his blood pressure fell to 75 by 40 and a pulse of 100 beats per minute. Patient shifted to tertiary care center for further management. Noradrenaline 5 microgram per minute was initiated and patient was transferred to cardiac cath lab, where a pulmonary artery catheter was inserted and showed the hemodynamic profile as follows. So this was the hemodynamic profile after pulmonary artery catheterization. Heart rate was 90, BP was 80/55, CVP 8, PCWP 19, cardiac output is 2.4, cardiac index is 1.4, SVR 1498, and this was the ABG. FiO2 0.4, pH 7.32, PaO2 64, PCO2 34, bicarb 20.6, lactate 2.8, and saturation was 90%. This was the monitor of the patient. So what are the abnormal hemodynamic parameters on this screen?
Sir, hypotension, sir.
So before starting this abnormal hemodynamic parameters, you should I should ask from you, what is your interpretation till now?
Sir, patient is in acute MI with cardiogenic shock.
Okay, acute MI with cardiogenic shock on the basis of history and examination, or you are including the lab values or lab values also?
How the appendix and ABG?
Sorry?
Cardiac index and ABG. Cardiac index and ABG.
Cardiac index and ABG. Okay. So what are the abnormal hemodynamic parameters in this screen? Blood pressure is low. One thing, blood pressure is low. Another thing?
Pulmonary capillary wedge pressure 19, sir. Greater than 18.
Pulmonary capillary wedge pressure.
Greater than 18.
Okay. So what it signifies?
Patient is adequately filled.
Okay. And what about cardiac output? SVO2?
SVO2 is low, sir. It is less than 65-70%, and cardiac output is low, 2.4.
Okay. So what does it mean? Which type of shock?
It is the cardiogenic shock. Probably it is the not obstruct.
Why
failure.
not? Why not septic shock?
Because the total count was normal. There was no fever.
Therefore, vascular resistance is increased.
Yes. PVR, peripheral vascular resistance. What is the peripheral vascular resistance value?
1400 diagrams.
1492. It's not elevated, no, sir? So that it appears
cardiac index is 1.2 only.
Yeah, cardiogenic shock. Patient is having maybe MI involvement is large, like infarct area is more than 40%. That is unable to contract and give the output that much. So need some support like IABP. And, so first we will start with the inotrope.
What is your diagnosis? You said acute MI with cardiogenic shock.
Yes, sir.
Next question. Any other investigation you want to confirm your diagnosis?
Echocardiography.
Echocardiography.
Any other thing?
Echocardiography. BNP.
And anything else?
That's it, sir.
Angio.
Okay. What about cardiac enzymes?
Yeah, cardiac enzymes.
But already it's a ST addition MIs. So,
but cardiogenic shock, decrease in cardiac output, cardiac index, along with normal or increased SVR in favor of cardiogenic shock. Or you can say if filling pressures are high, then it's a cardiogenic shock. In septic shock, low diastolic blood pressure, hence low mean arterial pressure, along with decreased SVR. Cardiac output remains normal or high in septic shock. In hypovolemic shock, SVR remains high with normal cardiac output. Or if cardiac output is a little bit less, the most important thing is the low filling pressure in the hypovolemic shock. So if filling pressures of all the four chambers are low, then you are dealing in hypovolemic shock, because sometimes there is a decrease in cardiac output in hypovolemic shock also. So filling pressures are very important. If filling pressures are high, then it's a cardiogenic shock. If filling pressure is low, then it's a hypovolemic shock. And if DBP is low, diastolic blood pressure is low, it means septic shock. So if pulse pressure variation, जो है pulse pressure is what is the pulse pressure? Systolic minus diastolic. So if pulse pressure is high, means diastolic is low, systolic is normal or little bit high. So if difference is much greater than 40, then it might be septic shock. But in this case, 81/55 means both systolic as well as diastolic blood pressures are low. So it is not fitting in the criteria of the septic shock. Okay. So by these values, you should understand which type of shock you are dealing. It's not necessary patient MI should have cardiogenic shock. It may be a mixed shock. It may be some underlying infections, septic shock, and patient get septic cardiomyopathy. So picture may be confused. So you should be very clear in your mind. What are the filling pressures, PCWP, CVP, and in this case, you can see the PCWP is high. So it doesn't fit in the criteria of the hypovolemic shock. If CVP is less, PCWP is less, then only you can think there might be hypovolemic shock. Okay? Because in trauma, there may be some high chances of the hypovolemic shock. So after differentiating which type of shock you are dealing, you should go for the cardiac enzymes as well as echocardiography. So cardiac enzymes, CPK value is 200, CPKMB is 36, TROPA is 0.9, and 2D echo as shown. So what is this?
For example,
Rupture of interventricular septum, sir?
Sorry?
Is it rupture of interventricular septum?
How can you say?
There was some valve-like thing. Another. Some space.
Space between?
Septum and papillary muscle.
So echo shown that severe anterolateral and apical hypokinesis with EF of 25 to 30%. Can everybody appreciate this with the video or not?
Yes, sir.
And can you show again, sir? I had lost for a few seconds, sir.
Okay. Can you see apical portion is not contracting properly?
Yes, sir.
So this is apical hypokinesis. And ejection fraction is definitely not the normal, because for the normal EF, there should be vigorous contractions. So there is no vigorous contractions. That's why it's a low EF. Or this is the eyeballing. Not necessarily you are absolutely right, whether it's a 35%, 40%, or 25%. You have a wild guess. It may be 25 to 30%. Okay.
okay.
So what will you do for that? क्या करोगे आप?
I can start with some inotropes like dobutamine with epinephrine or norepinephrine, I mean to say, or some milrinone with norepinephrine. I can start with. If it's still not, it's still the cardiac output is not improving, then I will go for the IABP, and still not, then LVAD, sir.
Okay, so what is the role of IABP?
Bridging therapy.
How it helps?
In IABP, the
Decrease of the load.
Sorry?
Increases
Decrease
coronary
reload and decrease of the
perfusion,
load.
sir.
Increase the?
increase the diastolic blood pressure by inflation at the aortic diastole. It improves the diastolic blood pressure, that improves the coronary perfusion. So that helps in the improve the oxygen supply, and it deflates during the aortic systole. In that way, decreases the afterload and decreases the work. In that way, it helps.
Okay, so in this case, we started with IABP, and norepinephrine and dobutamine drip was started and showed the hemodynamic profile as follows. And in the meantime, coronary angiography was quickly performed, which revealed a 100% mid-LAD obstruction, 90% proximal circumflex stenosis, and 85% stenosis of distal right coronary artery. Okay. So this is a little bit about the IABP curves. Timing is very important to understand the IABP, because in this type of vignette, they can give you the timing of this IABP curves. So they can ask you, we started the IABP and this is shown the first A curve or B curve, and what is your diagnosis? Is it right or not right? So it's early deflation, late inflation, late deflation. So you should be very clear in your mind what is the what is the A graph is showing.
Early inflation.
How can you say this thing?
Because the dicrotic notch, it's not there. So maybe it has started before dicrotic notch. Like this like this, it's not there, sir. That is
okay. Early inflation.
Yes.
And what about B?
This is delayed inflation.
After the dicrotic notch.
It is after the dicrotic notch. It should be just immediately, like should not be lag periods.
Okay, and what about the C?
This one delayed deflation. Delayed deflation.
Okay, and D?
This is early. This is early deflation. I think I am saying wrong. This is maybe early deflation, and this is delayed deflation.
So basically, this C is early deflation, and D is late deflation.
Yes.
And the problem is that in the physiological effects of each and everything is basically the benefit of is decrease in oxygen demand, and the coronary perfusion improves with the IABP. So in all the scenarios, all the 4 scenarios, there will be decrease in the coronary perfusion pressure along with the increase in oxygen demand. So this is the basic problem. So afterload reduction is essentially absent in D, and that will increase the myocardial oxygen consumption because of the left ventricle ejecting against a greater resistance. Okay. So you should know the graph. You should recognize the graph A, B, C, and D, which one is early inflation, late deflation, and what is the physiological effect. This is very important. They always ask in the vignette the timing of the IABP. And this is the ratio 1:1, 1:2, 1:4. So if augmentation with each and every beat, then this is 1:1. And augmentation after 2 beats, then it's a 1:2. And after 4 beats, then it's a 1:4. So they can ask these 2 or 3 things from the IABP. What is the assist ratio? What is the timing problem? And the need of IABP and the physiological effects of the normal IABP or with the faulty timings. So these are 2-3 things are very important. And along with this IABP, they always ask about the contraindication, absolute contraindication. And they can ask from the X-ray, how can you see the a small dot you can see in the X-ray of the IABP. So these 4-5 questions they ask related with the IABP.
Okay, thank you so much.
Okay, bye-bye.
Okay, sir.
Okay, sir, thank you.